Hi, and welcome to the American Society of Echo E3 lecture series. My name is Lucy Safi, and I'm Director of Interventional Echo at Hackensack University Medical Center and Chair of the ASE Emerging Echo Enthusiasts, also known as E3 Special Interest Group. This special interest group provides an opportunity for early career physicians, sonographers, and trainees who are interested in echocardiography to present, interact, and discuss echocardiographic topics. Each topic is formatted as a 30-minute didactic lecture followed by a panel discussion. On the panel will be two moderators and an expert in the field. During the discussion section, the panelists will also answer audience questions, so please enter your questions in the Q&A box below. This virtual lecture series will be recorded and later be available online on the ASE E3 website. To join ASE E3 Special Interest Group, log into your ASE account and under Update My Profile, click on Specialty Interest Groups and then E3. I would like to introduce my co-moderator, Dr. Daniel Forsha from Children's Mercy, Kansas. Dr. Forsha completed his pediatric residency, cardiology fellowship, and a master's in health sciences at Duke. He has been working at Children's Mercy for the last 7 years, primarily as a pediatric echocardiographer and researcher, and is now the Director of Imaging Research. He is currently the co-chair of the Pediatric Task Force of the ASE Image Guide Echo Registry, on the E3 Track Planning Committee for the 2022 Scientific Sessions, and on the writing group for the updated Transthoracic Echo Guidelines paper coming next year. Welcome, Dr. Forsha, and thank you for being my co-moderator today.
Thank you much. Happy to be here.
Our physician expert is Dr. Landeck. Dr. Landeck is a pediatric cardiologist and director of echocardiography at Johns Hopkins All Children's Hospital in St. Petersburg, Florida. Dr. Landeck completed his pediatric cardiology fellowship at Tulane University and the University of Virginia, including a year of advanced echo training. He is a fellow of the American Society of Echo and has served on multiple ASE committees, including the Guidelines and Standards Committee, Finance, Membership, CME, and the Pediatric/Congenital Heart Disease Steering Committee. He is the senior author on the ASE Guidelines document referenced by Ms. Wasserman in today's program. Welcome, Dr. Landeck, and it's a pleasure to have you here today.
Thank you. Happy to be here. Thanks for inviting me.
Our guest speaker today is Melissa Wasserman. Melissa is a satellite operations sonographer lead at the Children's Hospital Philadelphia, where she has spent the last 18 years of her career. Melissa has served for extended terms on the ASE Council for Pediatric and Congenital Heart Disease and is currently the Guidelines and Standards representative for the Council in Cardiovascular Sonography. Melissa also served on the Living Guidelines Work Group, Women in Echo Work Group, and on the CASE editorial board. Most importantly, to this particular webinar, Melissa was the lead author on this year's March JACE guideline publication entitled Recommendations for the Adult Cardiac Sonographer Performing Echocardiography to Screen for Critical Congenital Heart Disease in the Newborn. Welcome, Melissa. You may share your slides.
Thanks, Dr. Safi. And thank you to the ASE E3 Special Interest Group for inviting me to speak today. Today, we are going to be talking about screening for congenital heart disease. I have no conflicts of interest. So some facts about congenital heart disease. Congenital heart disease, I think, used to just be associated with pediatric cardiologists, pediatric sonographers, and I think the adult world kind of just put it out of their minds. But congenital heart disease is really common. It's the most common birth defect affecting 1% of live births in the US. And 1 in 4 babies born with congenital heart disease has critical congenital heart disease, which means it's a form of congenital heart disease that requires intervention within the first year of life. Of this population, 2/3 of the congenital heart disease population are actually over the age of 18. So if we did this talk 40 years ago, that would not be the case. But the survival rates of these patients has really improved. And now these patients are living into adulthood. And therefore, the amount of patients that are adults with congenital heart disease actually is larger than the amount of patients that are not adults that are under the age of 18. Circulation 2016 said that for every 1 million children with congenital heart disease, there's 1.4 million adults with congenital heart disease. So I think that this really takes away the separation of adult versus pediatric echo sonography. And as we said, survival has really increased with these patients. So about 97% of babies born with non-critical congenital heart disease are expected to survive to 1 year of age, and about 75% of babies born with critical congenital heart disease are expected to survive to 1 year of age. Of those, about 69% of babies with critical congenital heart disease are expected to live into adulthood. So again, it's important for all sonographers, cardiologists, whether you're adult or pediatric trained, to just have some familiarity with congenital heart disease. The first bullet point says survival of infants with congenital heart disease depends on the severity of the defect and how it's treated. But something that's really important to me is when it's diagnosed. And I think that for us in the audience of this talk, sonographers that have to scan babies while they're still inpatients in the newborn nursery, when it's diagnosed is really critical. Some of these patients have lesions that are ductal dependent, so they need that ductus arteriosus to stay open in order for them to survive. Some of these patients still need their pulmonary vascular resistance to be high in order for them to survive until they get to a place where they can be treated appropriately. So when it's diagnosed is really important. A lot of sonographers and actually cardiologists have asked me why we still see babies in the newborn nursery that didn't get a prenatal diagnosis, because here in the US, we have really good prenatal care, and there are still many cases of patients that are born with critical congenital heart disease or congenital heart disease in general that was not detected prenatally. And we found that there is significant geographic variation in prenatal detection rates, with a low in some states of only 11%. And what was found is that lesions identifiable on a 4-chamber view, such as atrioventricular canal defect or hypoplastic left heart syndrome, have higher detection rates of about 67%. And this makes sense because I think even if we spoke to OBGYNs, most sonographers and OBGYNs that do level 2 ultrasounds feel comfortable getting a 4-chamber view of a fetus. And they're more readily easy to get when you're scanning, but lesions requiring outflow tract visualization, such as transposition of the great arteries, have considerably lower prenatal detection rates of about 25%. And this is hard, right? So if you have a patient with maternal diabetes, patients that aren't referred to for prenatal care until like deep into their 3rd trimester, if there's multiple gestation, it's hard to get outflow tracts on all of these fetuses. So outflow tracts are definitely more difficult to get. And then prenatal detection rates remain poor for conditions such as total anomalous pulmonary venous return and aortic arch obstruction due to fetal cardiac physiology and associated challenges. So an example of that is if you have a patient with a coarctation of the aorta, in utero, it's really difficult to make that diagnosis unless you have really long segment coarct. But if you have a discrete coarctation, there's a small narrowing of that arch. As long as that ductus arteriosus remains open, it's really difficult to tell that when that ductus closes, that arch is going to be a problem. That's going to be a coarctation. And the same with pulmonary, not total anomalous pulmonary venous return. They're not always easy diagnosis to make outside of being a fetus. So these detection rates remain poor. Why is this important to the adult community just as much as it is to the pediatric community? So a common feature of many forms of critical congenital heart disease is hypoxemia due to mixing of oxygenated and deoxygenated blood. But this has to be really significant, like an O2 stat of less than 80% for cyanosis to be visible to the naked eye. If you combine that with patients with pigmented skin, such as the Black or Hispanic population infants, it is very difficult to tell just by looking at the baby if they're cyanotic. I've definitely seen babies that look pink and they end up having a form of congenital heart disease like tetralogy of Fallot. So pulse oximetry is a widely accepted non-invasive method to measure oxygen saturation of the blood, and it can detect hypoxemia at much milder levels. So a patient whose pulse ox is 88% or 90%, it's not normal, but if you look at them, they don't look blue. And so in 2009, the American Heart Association and the AAP issued a statement really presenting hard evidence that there should be routine use of pulse oximetry to detect critical congenital heart disease. And the sensitivity and specificity was pretty good for pulse oximetry performed after 24 hours. Specificity was 99%. And so in 2011, the US Secretary of Health and Human Services added the critical congenital heart disease screening using pulse oximetry. And it's been universally accepted. So this is just part of every newborn screening in the US. And why it's important to us as echocardiographers is because unlike other newborn screening exams, if you fail the pulse oximetry screening test, it mandates immediate evaluation for critical congenital heart disease. So this includes obviously physical examination if the physician feels a chest X-ray is useful or an EKG, to assist with diagnosis, but echo is the diagnostic modality of choice for definitive diagnosis of congenital heart disease. And while there are many community hospitals that have labor and delivery units and newborn nurseries, and there are a lot of community hospitals with level 2 NICUs, there are not many pediatric cardiology departments, as many pediatric cardiology departments as there are hospitals that do labor and deliver babies. So this results in adult sonographers and adult cardiologists being asked to scan, image, interpret echocardiograms on newborns. So sonographers, cardiologists have reached out to ASE and said, we just need some guidance. We don't know what to do. We're being asked to scan more and more newborns, and we don't want to miss anything. At the end of the day, we want to make sure that these babies are taken care of, and we need guidance. So the American Society of Echocardiography turned to the Council for Pediatric and Congenital Heart Disease and the Council on Cardiovascular Sonography and said, can you guys get together and kind of help out this community? And we said, of course. And what came of that were guidelines that were published this year, recommendations for the adult cardiac sonographer performing echocardiography to screen for critical congenital heart disease in the newborn. It's important to note that these guidelines contain 35 videos, and it's available for anyone, so not just ASE members. What we really felt strongly about was the sonographer that gets called to go do a newborn on, a newborn who's statting 80%. And before they even go down there, they're already panicked. And so if they can go onto the ASE guidelines and look and see what they're supposed to see, like which views to look for and some telltale signs, and they can have that, they can even pull it up on their phone bedside. The improvement of the studies of those patients and the odds of that patient really being treated appropriately and in a timely manner has really increased so much. So these recommendations are open for anyone to see, and there are tons of video files, which we thought a lot of us, it's one thing to read where you're supposed to put the probe, but it's completely different when you actually can see it. And not only do we show videos of echocardiograms, but we also show videos of sonographer probe placement on an actual patient. So it's one thing to read to sweep, it's another thing to actually watch a sonographer's wrist do the sweep. So the CDC said that there are specific targets that pulse oximetry screening really goes for, targets of critical congenital heart disease, and they list them. They're detransposition of the great arteries, tetralogy of Fallot, tricuspid atresia, truncus arteriosus, total anomalous pulmonary venous return, hypoplastic left heart syndrome, pulmonary atresia, coarctation of the aorta, double outlet right ventricle, Epstein anomaly, interrupted aortic arch, and single ventricle. I once heard an adult sonographer say that everything with pediatrics is intimidating because it's all letters like ASE, VSD, TGA, TOF. So I try not to use the letters anymore because a lot of the terms, the names of these forms of heart disease actually describe what they are. So, so these are the 12 targets that the CDC recommended were most clearly evaluated and picked up with pulse oximetry screening. So the first thing that we said was, A, familiarize yourself with those 12 targets, but B, develop a protocol. And we recommended that a standard adult echocardiogram protocol can be followed because congenital heart disease, and especially critical congenital heart disease, should be demonstrated in all echocardiographic imaging planes, but also because that's what we're all most familiar with. If you're an adult sonographer and you're scanning a baby, I think the anxiety of scanning a baby is probably already there. And then when we throw in like, use all these pediatric views, you're like, whoa, that's a lot. Let me stick with something that I'm comfortable with. So what we did for the majority of these forms of heart disease is we tried to show findings for critical congenital heart disease in the parasternal and apical windows, because they're, at least the parasternal long and short, it's universal for the adult or the pediatric sonographer and cardiologist, right? It's the same. We do the same views in parasternal for both adult and pediatric patients. And you can see telltale signs of critical congenital heart disease in these views. So a standard adult echocardiogram protocol can be followed for sure as your base. It's the base of your echocardiogram. But if you're going to be scanning pediatric patients, it's really important to start incorporating non-standard and traditionally pediatric imaging views. And these include subcostal views, suprasternal views, ductus arteriosus views, and we will go into them and you will see them and you will see where to put the probe down. And we really recommend practicing these views even on non-pediatric patients because you scan adults all day, and the more subcostal sweeps you do, the better you're going to get at them. So even if you're doing them in an adult patient and the patient has nothing wrong with them, the more you do, the better you'll get at doing them when you do have a pediatric patient. We recommend practicing sweeps, deliberately capturing long video clips of data. So this means not just clipping a parasternal long axis view and then angling posteriorly and clipping that tricuspid tilt and then unclipping and going back to your pulmonary valve. It means showing all of that in one sweep. So you hit record and you start at parasternal long axis and you slowly go posterior and then slowly go anteriorly. And that's a sweep. And we want to see it. Even if you yourself don't realize what you're recording, we may know what you're recording. So the reading cardiologist or the sonographer, the pediatric sonographer who's helping you with the study can say, you know what, you captured it. You didn't even realize you captured it, but you did. We also recommend in all imaging views doing complete sweeps of the heart to demonstrate relational orientation of cardiac anatomy. And I think that this is really important because I think in adult patients, it's just assumed that the aorta is posterior and rightward, and the pulmonary artery is anterior and leftward, and that is not always the case. And you can't really determine that unless you show how they fall and lie in relation to each other. So just showing an outflow tract by itself doesn't tell the whole story. So for us, a complete sweep, I always say if you're doing a subcostal sweep, I want to not see the heart on the screen. And then I want you to sweep until the heart comes into the screen. And I want you to keep sweeping until that heart falls out of the screen. So we know that we saw the heart in its entirety. And again, I keep going to subcostal views because we're big fans of subcostals. We emphasize subcostal views, just like adult patients with COPD that have no parasternal windows and sometimes very difficult apical windows. Newborns can also have some lung artifact, and sometimes the parasternal windows aren't the best, but just like we can get a short axis view from subcostal in an adult, sometimes when you can't get an M mode from up here, so you go below and you can get that short axis view of the left ventricle. Subcostal views are also really great for pediatric patients. I tell my fellows, we can get coronaries from below too. Like if you want to, you can get a lot of information just from your subcostal sweeps. And they are also really useful for Doppler interrogation of outflow tracts. So again, sometimes your parasternal views aren't the best. And sometimes even that apical view for an LVOT isn't really like amazingly on point, but from subcostal, you can really get great parallel with flow views for Dopplering outflow tracts. And this table I love, and not because we talk about the description of a parasternal long axis sweep, right? I feel like most of us know that we put our probes in the left sternal border with the transducer orientation toward the right shoulder. But what's most important on this table are these imaging tips that are in this last column. And one that I like in particular is the apical 4-chamber sweep, which is like when you put your probe down and you're not getting any image in the apical view. It may be because the cardiac apex is not always on the left. This patient may have dextrocardia and that heart may be on the right. And same with suprasternal in the adult population. I know we would just put the probe in the suprasternal notch and we would get a beautiful candy cane view. But for kids, it's not always the case. And something that I say it's a 2-second fix. It takes 2 seconds to do, and it makes a huge difference, is to hyperextend the neck by rolling a towel under the baby and put it under their shoulder blades, and it'll just naturally hyperextend their chin, and their chin will just lift up without actually pushing the baby's chin up. And for subcostal 4-chamber sweeps, the imaging tip that we gave was that image quality may be improved by placing the probe more inferiorly. I know a lot of times when we do subcostal views, we go right under that xiphoid process, right? And we're like, I don't know, I'm not getting images. But the liver is actually a great acoustic window. So sometimes by actually moving your probe away from the heart and more inferiorly and rightward, you actually get a more beautiful window. So this is like my favorite part of this table is really right here, these imaging tips. And then we went and moved on to non-standard views. And so these are subcostal windows, the ductal window, and the abdominal aorta. And what I like about these is that for all of these non-standard views, we show not just what you're going to see on the screen, but you're also seeing the probe placement, where are the notches, and the actual wrist motion of that sweep. So here we see a subcostal frontal view. To the left, you can see the actual sweep. And to the right, you can see what you will see on the screen, the corresponding echo image. We do the same thing for the ductal view. And we actually do this for all of the non-standard views, so that an adult sonographer, we don't just say like, do a ductal view. You can actually look and see what the ductal view is. And here you can see both branch pulmonary arteries. Here's the descending aorta. And here with color flow, you can see the red ductus arteriosus. And my son. Step 2 is become familiar with pertinent telltale echocardiographic findings associated with all forms of critical congenital heart disease. Again, we try to stick with parasternal views because they're the same. And I think that most sonographers know more than they even realize that they know. So for example, if somebody put their probe down for parasternal long and you were able to see both 2 outflow tracts in the same view, and you're just in your standard parasternal long axis view, side-by-side great vessels are going to make you start to think, I don't normally see this. And this is like your textbook telltale sign of transposition of the great arteries. And here's that video clip, the same still frame that I just showed you. And again, even if at first you said like, maybe this is aorta and this is the pulmonary artery, it's weird that I'm seeing them in the same plane, but like, I'm just going to go with that. if you keep going distally, you can see that this more posterior great vessel bifurcates into what is branched pulmonary arteries. And that may be your secondary sign to say, wow, I have side-by-side great vessels and the posterior vessel bifurcates. I'm going to start thinking about transposition of the great arteries. And so we go through all 12 forms of critical congenital heart disease and show these views, the one thing that should stay in your mind for each form. Same with tetralogy of Fallot. You'll see this your standard peristernal long axis view. You'll see an overriding aorta and a VSD. And I think even if you weren't able to say this patient has tetralogy of Fallot, you would definitely be able to say there's a blunt edge to this ventricular septum. The aorta is definitely straddling the ventricular septum, and we can see that there is a VSD. So again, this is not a fancy pediatric view. This is your normal peristernal long axis view. And we can see that this patient has tetralogy of Fallot, even without really seeing right ventricular hypertrophy or any pulmonary stenosis. Same thing, moving on to a peristernal short axis view, but still parasternal. This is a patient with truncus arteriosus. And when we get to the level of the aortic valve, we're seeing that there's a vessel that bifurcates coming off of where the aorta should be. Because that's not an aorta, it's just a common trunk, and those are the branched pulmonary arteries. And this is, again, like your textbook telltale sign of truncus arteriosus. And this is what that would look like in peristernal short axis if it was actually playing. So again, even if you couldn't say like this patient has truncus arteriosus, everyone would be able to say, I don't usually see branched pulmonary arteries coming off of what I think is the aorta, and clearly they are right here. Step 3 is, even if not able to specify the type of critical congenital heart disease encountered, the sonographer or echocardiographer should be able to identify red flag findings. So even if we don't know what the actual type of congenital heart disease is, if you put your probe down and you see marked left AV valve regurgitation and a huge left atrium, the next step is to start thinking, why would this newborn have that? What could the diagnosis be that would make a newborn have such AV valve regurgitation? And so for each form of secondary red flag findings, we listed what the actual finding could be. So this patient could have a cardiomyopathy or LTGA. And we went through all kinds of different secondary findings. So here's another red flag finding of abnormal atrioventricular valve anatomy. And this could be that one of the AV valves is hypoplastic, or there just looks like there's one AV valve. And this could be associated with atrioventricular canal defect, with mitral stenosis, with Epstein anomaly. And again, if you put your probe down in apical and you saw this, you would be able to say that's not what a normal mitral and tricuspid valve look like. Even if you weren't able to say that this is a common atrioventricular canal defect. Step 4 is, can you answer these 3 questions? I think a lot of times sonographers, we know more than we even realize that we know. And I've had sonographers call me they're adult sonographers, and they're calling me from a newborn nursery, and they're like, I have no idea, there are vessels everywhere, there's red flow, there's blue flow, I don't understand what's happening. And I always say, like, take a deep breath. Can you answer these 3 questions? And the 3 questions always are, how is blood returning to the heart? How is blood getting to the body? And how is blood getting to the lungs? So if everyone could just stop, even the reading attending, and answer these questions, I think it will really help make things less scary. So whichever one you can't answer, that's really what you're going to go for, right? That's your goal, to try to answer that question. And these are really good questions to have answers to for your attending, whoever you're reaching out to. So if you have a pediatric cardiologist, you can absolutely say, you know, I see an aorta and I see branched pulmonary arteries, but I don't see pulmonary veins anywhere. I have no idea how the blood's getting back to the heart. I think it's really helpful, and it'll help the reading attending kind of guide you into what the answer may be. picture and video that we show in these guidelines is of a PDA that's all right to left. And here you can see the right pulmonary artery, the left pulmonary artery, and the patent ductus arteriosus. And instead of there being red flow, which is left to right shunting, there's blue flow. And we say that it's so simple. It's a simple finding. A PDA in itself is not a critical form of congenital heart disease, but it's a sign of critical congenital heart disease. So if you see all blue flow, it could be severe pulmonary hypertension, it could be coarctation of the aorta or hypoplastic left heart syndrome. And then there's like a little important note at the bottom of this table. And I think that I wish if Jace could have just taken the important note and made it like an entire page, it would have like made me so happy, because it's such an important note. It's really what I want to stress from this whole talk. If you can't make it look normal, it probably isn't normal. So if you can't get your normal parasternal long axis view, there's probably a reason for it. It's probably not normal. So trust your judgment. Trust that you know what normal should look like. And if you can't make it look normal, contact somebody, reach out and say, I'm struggling, something's not right. Thank you.
Thank you so much, Melissa, and congratulations on such an excellent guidelines paper. I wanted to, again, just reiterate how wonderful those videos are and that they're available online in the supplement. And you gave great examples of the sweeps and certain anatomies, and I encourage all who are listening to log in and check out those videos, because they're very wonderful and very well put together. I wanted to ask our expert the first question, if I may, and I wanted to ask, you recommended in the paper that we use the standard adult imaging protocol when you approach a patient with possible congenital heart disease. For the sonographers out there who are possibly scanning an adult, should they start in the peristernal view or in the subcostal view? How should they approach these patients?
Good question. One important thing we discussed in the paper was that a protocol should be developed between the institution that is performing the studies and the institution that's reading the studies. And so we did not want to specify how that happens. We want to leave that up to each individual relationship. I can tell you in my experience, depending on which pediatric echo lab you go into, some are going to start with subcostal imaging and some are going to start with peristernal imaging. And they both have their advantages and their drawbacks. And so I think what's probably the most important, not to dodge your question, but what would be most important to me is to make sure that you're consistent, that you have a protocol that's developed and that you follow that protocol. The advantage of a protocol in my mind is that it ensures that you're getting the information you need captured. And so to Melissa's point, if you don't understand all the anatomy you're looking at or the relationship of the anatomy, if you've at least followed the protocol, the information should be there so that a person who does have expertise in that area will be able to look through it and make the diagnosis.
Thanks, Biff. Melissa, great talk. This paper is really awesome. This is, there's not very many, I would even say amongst the guideline papers that come out that are just user-friendly. And this is one of the most user-friendly documents I've ever seen, in addition to just having imaging tips as your rightmost column there. And as some of the tables were flipping by, you could see them, but also just the really quick access, even before you go into the nursery, like Melissa said, just go up and quickly scan through these images, and you at least have an idea of what the goal is. If scanning newborn babies is something you do once every bunch of months, it's great. But all right, I'll start with Biff. But actually, this is a question for both of you. Any of us can take a shot at it. What do you think are the easiest misses? What in the anatomy? I mean, Melissa talked about a couple of them. She talked about transposition, which can be a little tricky sometimes. Talked about right to left at the PDA, but what do you think are some of the easiest misses you see, and how to kind of guard against them?
So I'll take a first stab at that. One of the things that I've always taught the fellows is that there's really one type of congenital heart defect that turning on PGE is not going to help, and that's obstructed total veins. in a newborn, and every institution has examples of times where that's been missed. I think that if you're having a hard time seeing pulmonary veins, one clue to me is to immediately go to the atrial septum. And if you only see right to left shunt at the atrial septum, I think it's you have to assume it's veins until proven otherwise, and then you go and prove that. So I would say that's one that I've seen missed before. It's easy sometimes to actually see color Doppler of pulmonary veins coming in, but what you don't recognize is that they're coming to a confluence that's posterior to the left atrium and not connecting normally. So that would be my probably easy miss that could be really detrimental to the patient if you did miss it.
Yeah, that's a nasty one. It's the first thing that pops to my mind too, because especially in pediatric world, we get so tied into, we call it the crab view, right? That kind of high parasternal view where you can see all 4 pulmonary veins coming into the left atrium at once. And that is such a trickster view for this particular one, because like you said, exactly, it looks just like it. When those 4 veins are coming back and it's total anomalous pulmonary venous return, but they come back and form this confluence right behind the left atrium and then shoot down or shoot up. In that view, you can't see the shoot down or shoot up. All you see is it coming back there. So that's, and nicely, I think for adult sonographers that, adults, they love the apical view. They do it the wrong way up, but, they do it very well. And so, they have those pulmonary veins that that's never the issue that I see when I see an adult sonographer study, is they've nailed the pulmonary veins coming in from the apical view, which is the key to not missing total anomalous pulmonary venous return. I'll try to be good, like Melissa said tonight, not use too many of our alphabets.
No, not too much letters.
There you go. What do you think, Melissa?
No, I agree about veins. It does look like they're coming into the left atrium. I agree with the right to left shunting really being the key there. I think that all right to left PDA is very easily missed. I think a lot of people think that it's the descending aorta, but it's not. So, you have to look for other things too, like flattened ventricular septums or flying W patterns or other things that would cause all right to left shunting. And I also think that coarcts are very commonly missed, especially in the setting of a closing PDA. So, it looks kind of small. There's like that ductal ledge, but like right now there's no gradient across it. And then that PDA closes and that arch really cinches down. So I think that that's also another form of congenital heart disease that actually can be critical, that is easily missed.
I was going to say that as my next one too, Melissa. I think coarct can be easily missed. It seems like, at least from my standpoint, such a relatively simple defect when you just think of it anatomically, but it's actually one of the most difficult ones to make the diagnosis on an echo when the ductus is still open, and you have to look for some, sort of secondary signs. One sort of, to get on my soapbox for a second, a plea to a sonographer as you're performing these echoes would be, when you're in the abdominal aorta, we ask for in a congenital heart screening echo to get a Doppler of the abdominal aorta. Make sure that you're not in the SMA or the celiac artery when you're doing that pulse wave, because you what you're looking for is a nice brisk upstroke and relatively quiet diastolic period. And you can trick yourself if you're in the SMA or the celiac, where those more medium-sized vessels show that diastolic continuation, which could lead to an unnecessary transfer of a baby who, you say maybe they've got coarctation because of this.
As an aside, that's also one of the videos that we posted, is what a normal abdominal descending aortic Doppler pattern is supposed to look like, and where in the aorta you're actually pulse waving, just to kind of show that it's not the SMA, but it's also not so high that if there was a coarct, you wouldn't get the pattern that you want. So that's actually one of the videos that we show. And that's another one that we have a sonographer actually showing where to place the probe to get that sample, that Doppler sample.
That's so great, because that angle of the probe is important there, right? That's how you get the good, clean Doppler signal, and not that terrible Doppler signal that you can't actually tell is if it's different from abnormal, or if it's, you know. So very nice. Yeah, one of the, it's simple. I think probably most of us would say the easiest misses are usually outside the heart, but right, the extra cardiac stuff, the stuff that isn't contained within the heart. Usually what's contained within the heart is a little easier for us. What's outside the heart is at all different angles and different babies. But I actually think VSDs at kind of the extremes can be pretty easily missed, especially if you're not sweeping all the way through. If you've got a real apical VSD, or real anterior, real posterior, if you're not following Melissa's advice there and starting behind the heart for most of your sweeps, or to whatever side of the heart your sweep starts from, then you could miss that very extreme VSD, and you know, it's not great. So
anterior muscular VSDs. I mean, if your color box, if it's not wide enough to really get that anterior muscular part of the septum, they're very easy to miss.
And, you know, to Dan's point on the VSDs, the best baby is a quiet baby. And sometimes the sonographers don't get that. They get a child who's, you know, screaming and crying, and those sweeps are challenging at those times. And so it is easy to miss a VSD. Since we're talking about screening for heart disease in general, just another tip, I guess, would be if you identify congenital heart defect, just because you see the major defect, don't forget to look at the rest of the anatomy for other secondary findings. We have all seen patients with a large perimembranous VSD, and then we missed that they also had an apical VSD. And that puts egg on your face when the surgeon goes to close the perimembranous defect and they come off pump and they still got a decent sized apical VSD.
Well, and that gets particularly tricky. Sorry, Melissa. That gets particularly tricky though, because if the perimembranous is big enough to equalize the pressures between the ventricles, right? Because then there's very low flow through that other one, and you have to have it's probably what, well, I'm not sure if that's what Melissa was coming around to, but you have to turn down that Nyquist limit, and you have to be real intentional about where you're sweeping to get those. Sorry, go ahead, Melissa.
Yeah.
No, actually, I feel that your settings are important for everything, right? So you're not going to get the best TR if your scale is at 115, right? So like, be mindful of what you're looking for. I've definitely seen missed VSDs because the scale is so high that you're just not getting anything crossing. But actually what I was going to say is we were talking about babies and not always being, you know, cooperative, or it's different. One of the things that I definitely recommend is not just having a naked baby, really only exposing the part of the body that you need to image at that time. So, you know, there are certain things you can do to improve the odds of you getting a really good study on a baby. And one of them is to have a sleeping, happy baby, right? So if that means, you know, using warm gel, or only exposing the parasternal window when you're doing parasternal, and then recovering that baby up, making sure you have a pacifier, asking a nurse who's nearby to stay with you and to be your pacifier holder, or if there's a parent to be the pacifier holder, asking for help. So I think beyond the fact that we're looking for critical congenital heart disease and or congenital heart disease in general, you could really improve your odds of finding it with like a happy baby before you even start the scan. So that's something also that I feel is super important. You want to give yourself the best chance of getting the best study.
Happy baby, happy sonographer, happy reader. less missed disease. So it's good. Yeah. And I find it's funny, we were talking about this earlier, Melissa. Parents sometimes are intimidated by the environment, I think. They're oftentimes a new parent, but just that they're so hesitant to help or to do things. Like sometimes just a comforting word of, hey, do you mind doing a little padding, or a little whatever's going to help you best in that situation. will get you an ally in that battle.
Do you ever scan babies with the parent holding the child if they're, if they're very young?
Yes. I've scanned babies as they're being breastfed. At the same time, I've scanned babies sitting upright in their parents' arms if they have bad reflux. Yes, we do. We will do anything to have that baby be calm and happy. So we will work around that. So yes, we do. Is it optimal? Absolutely not. Would I rather the baby lay flat? Definitely. But if the only way to do it is in the parent's arms, then that's what we have to do. Most of the time I'll have them try to help. So if we're doing like arch imaging, I'll have them let the baby's head fall slightly over their arm just to kind of let us get in there. But yeah, I've scanned babies in many ways.
And I agree with all that, but I'm going to try pretty hard not to scan a baby breastfeeding.
Yes.
What I would say is, if you're scanning an older kid, though, it's not a newborn, but let's say, you're asked to scan a 6-month-old or a 9-month-old, and they're a little stronger and they're fighting you, like actively restraining the baby is not going to help. So you don't need to have a parent like pin their arms back. That's just not going to get you where you need to be. What you really do in that situation is try and sort of reset, maybe step away for a minute and see if the baby will calm down. Maybe ask a parent, do you want to try breastfeed for a minute or bottle, and then come back in a few minutes and maybe you'll have a more cooperative kiddo.
So Biff, let me ask you this, as a reader of during my reading day, I know studies are going to come in from my internal sonographers at my institution through my protocol, and we've done a lot of education and QI and all that to make it just so. And then I know a bunch of studies are going to come in from other places with sonographers who are not as used to doing this. And when it comes to reading it and trying to rule out not only critical congenital heart disease, say in a baby, but just congenital heart disease in general, how do you think about the study that comes in from the outside institution, and how do you try to put it in the report in such a way that you get your point across as far as how you're feeling about things?
That's a great question. There's an art to this. I think that you have to, number one, you're being asked to help, and so you want to try and help. You don't want to just hedge on everything or caveat everything and say, well, I couldn't see this, I couldn't see this, I couldn't see this. That's not helpful to the patient or to the person who ordered the study. You also have to make sure that you don't state that things are normal when you can't see if they're normal. And so what I'll typically do is be honest and say, here's the things I can see, here's the things I can't see well. And then I look at the indication for the study. And if it's being done for, cyanosis, and I am having a hard time telling whether there's a small muscular VSD or not, that's probably not really pertinent to the cyanosis. So I feel a little better about leaving that alone. But if it's a kid with chest pain with exercise and I can't see the coronaries, then I'm going to, say that pretty definitively. I can't see the coronaries. And I will try when because I call back results to the ordering provider to put it in context and say, I can't see the coronaries well, but this was done for a heart murmur. So it probably isn't, something you were worried about. And so, maybe we don't need to follow that up versus actually, I'd recommend this patient come to a pediatric heart center so that they can have somebody scan who's really used to using echo to look at coronary artery origins and look at the, anatomic features. I think that's probably my approach to it.
I agree. That's usually what I'm trying to do is decide, well, answer their question if at all possible, their primary indication. That's, I always, it's rough when you don't feel you have the images to answer their primary question, but then just can I phrase this in such a way that they're comfortable with not being seen again, or does this report need to be written in such a way that, there's follow-up that needs to happen here? So yeah, I totally agree.
The other point I'd make is that it's not like there's no shame in having to go back and get some more images if you can't see everything. And I do that in our own lab with our sonographers. If there was something I needed to see, I'll ask them if they can go back. The advantage is I work with them all the time, and if need be, I can go back in the room with them. I can't do that when I'm reading a study from an outside institution, but I can talk to that sonographer and try and walk them through, you know, we're going to try and see arch-sightedness. I didn't see that well. It's important for this baby to determine, for whatever reason, maybe they have TE fistula. And I'll you know, try and see if I can get on FaceTime with them or something and say, hey, here's how I want you to hold the transducer. Here's how I want you to sweep, and see if I can help them in that regard.
I think something also, though, important from a sonographer's perspective for the reading attending is if the patient does have to come back, let's say you see a VSD, so you know that that patient is going to come back for secondary studies. It's so important for us to know in the summary what you didn't see previously, because otherwise I'm going to assume that you guys did a full complete study and that the only thing that you found was this VSD. But if you put the patient has a VSD, but also we never saw the coronaries, that's going to tell me that now I have to go and look for those coronaries. If it's not listed there, I'm gonna go ahead and assume that all other cardiac anatomy was defined. So I do think it's really important, as important as it is as stating the finding is stating what hasn't been seen, so that we know that we have to still go and get that.
And the centers that have the best relationships between the performing and interpreting centers are going to have two-way communication, not just, you know, one-way communication. So the sonographers need to feel very free to contact their pediatric cardiologists and say, hey, I'm not sure, I'm worried about this, because that's what happens day to day in our echo lab.
There was an audience question from Carrie. Melissa, maybe you can add your input on this. How do you describe to adult echocardiographers how best to find the coronary arteries?
So there are some things I always say about the coronaries is if you can't find them in the normal locations, open your mind that it may not be because you're a horrible sonographer. It may be because they're not in their normal locations. And I think that that's something really to keep in mind, because I've definitely seen sonographers say, like, you know, I couldn't get the right coronary. And I'm like, yeah, that's because it's completely anterior and leftward. You're not going to get it at 10 or 11 o'clock because it's instead at 1 o'clock. So I think that's something important to go into it thinking, you know, go into imaging coronaries knowing that while they should be, you know, the left at 3, let's say, and the right at 10, they're not necessarily there. I've definitely seen left coronaries that originate somewhere between 4:30 and 5 o'clock and kind of sweep upward. So before even starting, I would go into that. The other thing I definitely recommend is decreasing your compression, which lowers the amount of grayscale that you have. So it makes like the white images very white and the dark images very dark. And I also love two-dimensional imaging. I know everybody loves color and it is important to use color, but color is your second way of defining coronaries. Your first one is by 2D, and I don't want to see a still frame. You've got to show it moving. And this is something, again, that you may not even realize that you got. You may have it. You are looking at branch pulmonary arteries and you happen to get your right coronary artery in there too. So definitely long clips of coronaries for sure. Decrease your sector size, right? So a smaller sector size, because you know what you're concentrating on. I don't need to see the branch pulmonary arteries when I'm looking for coronaries. Decrease your sector size, decrease your compression, make sure you show in 2D. I find the right coronary usually comes off like more anteriorly, so you kind of have to angle your probe a little bit higher. And then I also find sometimes when I over angle or I over correct in parasternal short axis, that I can get the left main bifurcating into the LAD and the circumflex. And it may not be when you're like on FASE with the aortic valve. You may have to be actually over rotated to get that. Do you guys have any additional recommendations?
I mean, I would say it's not uncommon for me when we're having a hard time seeing a right coronary to see that it actually comes off up at the sinotubular junction or even above that. So don't be
Like
afraid to rotate.
parasternal long axis?
Yeah, so rotate over to the parasternal long and you might see it there.
That's exactly what I was going to say. But I will say also that coronaries, some of the most challenging things we do, they're tiny and they're little babies and they can come off at a lot of different angles. It's one where you really need to know your knobology. You need to, Melissa listed off a bunch of settings there, got to have that Nyquist lowered. Oftentimes there are oftentimes in a pediatric center, there are machine presets that are really nice for pediatric coronaries. Now it's possible that you could get those on machines at any institution. You could, they're out there. But you really have to kind of fine tune those settings in order to get especially color fill of those coronaries, which yes, 2D is amazing, but I'm gonna want that color fill too. So
another thing is that you can increase your frequency, right? Because you want detail, right? We don't need penetration. You don't really need a lot of penetration to get coronaries of a baby. So I use as high frequency as I can get, and all of our probes, even if you don't like have a 12 hertz, probe, all of our probes have a range. So if we just move it to the highest frequency that's in that range, I think that's also helpful. And I also don't always think you need harmonics to get coronaries. So don't be afraid to mess with your frequencies.
all right. Well, I think 2-minute warning here. So this was an awesome session. I just enjoy talking to you people, but B, you're smart and have done a really cool thing here. I've got to give a quick shout out. Rita France was on this. She's Echo Lab director at my institution in Kansas City, and Anitha, who used to be our Echo Lab director, is on it as well. Love working with them, and I don't know. You guys have any final thoughts here?
Just try and do the best you can. Don't forget that you've got a resource in your pediatric echo lab for help on these things. If you have the opportunity to come spend a day at a pediatric echo lab, that can be helpful. They can some of the things that can be conceptually the most difficult for an adult sonographer to perform. Spending an hour practicing it with somebody who can show you the right way to do it, you'll learn that skill, and then you'll just have it the rest of your career. So it could be time well spent to spend a little bit of time, shadowing or sort of learning from a pediatric echo lab.
And I just wanted to say again that you put together a fantastic guidelines paper. For those who don't have the opportunity to shadow, definitely watch those videos and read the document. I feel like it's very educational. I want to thank you all for joining in tonight, and our next E3 lecture is going to be on November 15th. So I hope you all can join in. Take care and have a good night.
Great, thanks.
Thank you.
Bye, everybody.